Okay, thank you everyone for voting. We're going to get started. So take a little look at the screen now and we'll see if it's changed by the end.
Hello. Welcome to Symposium 21 for your consideration, a debate on de-escalating therapies. We have nothing, Melissa and I as your moderators have nothing to disclose related to these presentations. And we wanted to just begin with saying, as we pass the 6-year anniversary of the debut of highly effective modulator therapy, specifically ETI, we still find ourselves in a bit of a Wild West situation. We're trying to walk the balance of providing optimal care for the preservation of lung health for the people with CF that we care for, while at the same time we attempt to meet our patients where they already are and formally lessen their burden. We have some research available on de-escalation of standard therapies, but it's easy to admit we're still very much in the infancy of this major shift in treatment for a disease which still remains chronic and still has a nasty reputation for the development of devastating, severe lung disease and impairment. In addition, all of us as educated, critical thinkers can attend the same conferences, we can read the same literature, and still walk away with different interpretations of the data, which all too frequently is limited in various ways. So with that in mind, we turn to the 3 long-standing historical pillars that have stood the test of time in upholding the battle for the preservation of CF lung health. We have airway clearance, inhaled mucolytics, specifically Dornase alpha and hypertonic saline, and inhaled anti-pseudomonals. Today, we have 6 highly regarded clinical experts who have graciously agreed to participate in this symposium and are ready to battle the main question: how solid are these pillars now in the era of highly effective modulator therapy? Can we confidently knock down some or all of these pillars as we move forward in our practice? Our debaters have been asked to argue their points to the T, despite their personal views or current practice.
All right. So in our lineup today, we have a diverse panel of people who represent different individuals on the CF multidisciplinary team, the 3 Ps, the PTs, the physicians, and the pharmacists. They're here today to either bulldoze or build the pillars of treatment. We're going to see a battle royale from the sharpest minds in CF care. They will approach each topic with bold passion, bolstered by research, and perhaps even a bit of humor. For the first head-to-head, ready to champion the pro-argument for the de-escalation of airway clearance is CF Medical Director of the Pediatric Clinics just north of here in Vancouver, Canada, Dr. Mark Chilvers. But that is no Canadian accent you'll hear. Mark trained in the UK and made his way to Canada for his CF fellowship over 20 years ago. The poutine and beaver tails had him singing Shania Twain and sent him to work alongside the heavyweight airway clearance PT champion Maggie McElwain, who was actually supposed to present today. Due to Maggie's absence, Dr. Mark Chilvers didn't even blink and eagerly offered to step into the ring today. Trained as a respirologist and no formal airway clearance training, he has his work cut out for him, but he has a career worth of strong PT advocates that worked alongside him that helped build and maintain those pillars in his clinic. Dr. Chilvers serves as my clinic director, as well as the medical director for the BC Health Improvement Network for Cystic Fibrosis. He's a keen advocate for airway clearance, but is here today to challenge this pillar in CF care. So we want to thank Mark for stepping into the ring, and best of luck to him. But before he gets up here, opponent in the opposing corner is ready to defend the enduring role and pillar of airway clearance is none other than the highly esteemed physiotherapist, Dr. Gemma Stanford. Fan club in the audience. A rising force in the world of CF care, Dr. Stanford has made waves as part of last year's winning team in the NACFC debate, airway clearance versus exercise, and she comes again to debate for the continued role of airway clearance. She has traveled over 5,000 miles from the land of David Beckham and one of the most respected respiratory institutions in the world, the Royal Brompton Hospital in London, England. At the Brompton, she works as a clinical specialist physiotherapist in the adult clinic, where she brings academic rigor and compassionate care to her patients. Gemma completed a PhD that focused on outcome measures for airway clearance in adults with CF. And in all her spare time, she is lead investigator for the Yoga CF trial, examining the impact of yoga on adults with CF. Dr. Stanford is no stranger to the international stage. She has published and presented widely on a range of topics, including airway clearance and the emerging challenges of aging with CF. Today, she's here standing firm in her belief that while the landscape of CF is shifting, airway clearance still has a vital role to play. So we're going to welcome Dr. Chilvers up first, and then right after, Dr. Gemma Stanford.
Thank you very much for that very nice introduction. And in the words of gladiators, gladiators ready. And so, as you heard, yes, I may not be a physiotherapist, but I do know about the pores of Kohn and the channels of Lambert and Martin. But what Gemma did not know, I am a closet ciliologist. And so, known locally as Mr. Happy, today I'm going to prove to you all that I am Mr. Right. And how I'm going to do this is really with a very good way of taking down this pillar, to show that modulators, they support airway clearance. I'm going to show the highlights for what do the patients want. They don't want to do airway clearance. They want to get out and enjoy their lives. And is this supported by the recommendations from the standards of care which have been recently published? And then I'm going to explore the wealth of evidence supporting airway clearance. So, going back to the basics, modulators and mucociliary clearance. So here you see a normal ciliated epithelium with the periciliary fluid and the mucus overlying, and they move back and forth with the mucociliary escalator. Obviously, with cystic fibrosis, we're all aware that the defect in the CFTR channel causes that periciliary fluid to reduce and thickens the mucus. And so with the CFTR modulators, which are now available, we get restoration of the CFTR function up to about 70%. And so that really does improve this mucociliary escalator. And so therefore, we don't really need to do airway clearance because the body's already doing it. And what is the evidence to show that CFTR modulator medications will support airway clearance? You can see here from the PROMISE study, at 1 month, the quality of life has improved by 10 points. 15% of participants no longer produce sputum. So if they're not producing sputum, what is the role for doing airway clearance? And of those who are producing sputum, they are producing less. The mean sputum weight was 26% less at that. So already we're seeing that this mucociliary escalator is starting to improve with highly effective modulators. And then again, we've got our colleagues who are going to be up next. But when we look at whole lung clearance using radiolabel isotopes, those on modulator therapy, there's a significant improvement in the aerosol clearance from the lung. Again, the amount of sputum solids reduces on treatment, but also we're seeing a reduction in the bacterial load, be it chronic infection with pseudomonas or staph. And so when we reflect back onto that vicious vortex of the infection inflammation that we see in bronchiectasis and in cystic fibrosis, we're actually going to see that there's reduced mucus production and reduced infection. And similarly, airway clearance, it's 20 minutes. It doesn't have a long time. You can see here, this is on patients who have no modulator therapy. Certainly airway clearance techniques did improve mucociliary clearance, but when you stopped, the rate of decline from the radiolabeled isotope was the same as in the control group there. So airway clearance is important, but it's not sustained. Modulator therapy is sustained over time. And here is another image just to show why modulator therapy has improved. These are lung MRIs from my colleague, Dr. John Raymond in Vancouver. This is pre-modulator. The black bits in the lung show that this is impaired ventilation within the lung. Following modulator therapy, you can see those black bits have gone. There's improved ventilation, so improved airway clearance physiologically. And so we don't need to be thinking about doing airway clearance. But I look at the patient. That's where we always taught. And people will think of the physiotherapist. I worked in England. This is a picture of the physiotherapist, prim and proper. But how do the patients see their physiotherapist? Drill sergeants. That is how they see their physiotherapist. And with respect to my colleague, they do a very good job, but this is how we view our patients in Canada. And this is the CF Canada poster guy. I'm not talking about me, I'm talking about Stuart. Here he is, he's been on modulator therapy for 5 years, his lung function is pristine, his CT shows no evidence of bronchiectasis. So, Dr. Stanford, do you think he's doing physiotherapy? Well, when I got permission to use his photograph here, his mother said, you can tell him he's not doing any physiotherapy whatsoever. And so, this is a question. Patients are making these choices. And when we look at the James Lind Alliance, treatment burden is really important. And what's really interesting is this has actually gone down in the order of preference from patients. And the question I was thinking, well, is it because they're not doing their airway clearance that the burden of care has improved? But what's really interesting is this is a discrete choice experiment. So basically, it's putting a question. So the example would be, would you donate a kidney if the Blue Jays are going to win the World Series? And so what they've done, a lot of Torontonians would do that. But what they'd looked at was, what would you do to stop physiotherapy or reduce your physiotherapy time in half? And so they looked at that in terms of reduction in lung function or reduction in life expectancy. And so you can see here that patients would happily accept a 6% reduction in lung function to stop chest physiotherapy. Similarly, a smaller drop for spending half the time doing chest physiotherapy. But what's really interesting, they would actually have their life expectancy reduced by 3 years to stop doing physiotherapy. I bring you again, Drill Sergeant Stanford. And when we think about this, this is another study published in 2024. This is modulator-naive patients, and this is the amount of time that they were doing chest physiotherapy before they started on highly effective modulators, 6 months and 1 year. And at the start, they were doing 70 minutes of treatment, and then gradually you can see it's falling less and less over time. And when they looked at outcome measures such as lung clearance index and looking at FEV1, there was no difference over these subsequent time points. But airway clearance is declining. I looked at 3 registries. We looked at the UK CF Trust, at CF Canada, and at the CF Foundation. And you can see here that the UK CF Trust, close to 15% of patients reported not doing chest physiotherapy. Similarly, in the States, there've been an increase of not doing physiotherapy or airway clearance from 3 to 11%. Canada is a little higher because of the way that the data is collected, because if you don't have a answer, it's filled as none. But you can see that this is increasing as well. So when we look at that a little bit more in depth, certainly there's a 20% reduction in patients reporting doing PEP therapy, similarly a 10% in Canada. But what was interesting in the States, there's an increase in PEP. So why was that? Well, then when I looked at it a little deeper, it's because using the vest, there was a significant drop in number of people doing the vest therapy, and I think they're taking that up with the PEP. But we're seeing that there's a change here. And when we look at this in 2020 and 2023, looking at lung function and nutritional markers, when you had airway clearance being not done in 3% and 11%, there appears to be no long-term harm from this. So what do physiotherapists do? I often ask this. Obviously, I know, but obviously, pre-modulator, it was to maintain lung function, it was to improve quality of life, but it's also to individualize and allow patients to self-manage. It's about empowering patients. So I looked at this a little bit more. So what about in 2025? I went down to my clinic, I had a look, and there is my physiotherapist, and she's reading a book on sleep medicine. She is retraining.
I was set up.
So I thought, hang on, what can I do? I need some more information here. So I was able to meet up with the CEOs of CF Canada and the UK CF Trust. And I asked them the question, what do physiotherapists do in 2025? To which they said, I don't know. And so there's no consistency. So I thought, how can I answer this? So I went to the standards of care, and there's been 4 publications, 2 from the States, 2 from the European CF Society, looking at airway clearance and what we should be doing in the new era of modulator therapy. And so the first one was the model of care, and that's changing. And so I looked at this, and I was thinking, hang on, where are the physiotherapists? Oh, they're in the essential, but not part of the core team. Now, I recognize that different countries do different things in terms of airway clearance. In the States is done by respiratory therapists from there. But what this highlights is the roles of all our care team are changing as we move forward. And so I then thought, well, what about, does it mention airway clearance in the document? So I searched, and I searched, and I searched. And guess what, Dr. Stanford? Just like the UK and the Eurovision Song Contest, 0 points. No mention of it at all. And so I thought, okay, we'll move on. And so the European ones, we've got some mention here, but it's advice should begin at diagnosis. And I think this is really important. Airway clearance is important for patients who don't get access to modulators, or for the under 2s who don't have access to to modulator therapy. But it's looking at other ways of physical activity and exercise. And again, it's talking about this individualized self-management. And I think that's really important. So what about the data? Well, my colleagues are going to be talking about Simplify and CF Storm. And I was eagerly anticipating the Hero 2 data, which was presented yesterday. And one of the interesting things, at the time of enrollment, 1 in 5 patients had already stopped doing their airway clearance therapy before they looked at that. And from what Dr. Wren presented, overall, nearly half had stopped some chronic disease therapy at the time of enrollment. The most important thing was that discontinuation was not associated with increased pulmonary exacerbations, was not associated with a FEV1 decline. And so it suggests that patients with CF can discontinue their therapies without adverse pulmonary effects. So, to summarize, patients don't want to do airway clearance. PEP gets thrown into the bin, and they're choosing not to do it. You see it. The poster boy from CF Canada, he's not doing his airway clearance, but he's doing okay. But really, it's have we missed the boat? And I would postulate now that Dr. Stanford, really, if she wants the evidence, the PEP horse has left the stable, and we're trying to close that stable door. And I think we need to really focus on individualized self-management. For those patients who are not doing airway clearance, we need to support them, not bring them in and say, you should be doing this. Explaining when indications to do airway clearance are appropriate, such as when having a pulmonary exacerbation. Thinking about exercise, thinking about adjuncts to this. So with that, I'm going to end. I'm going to hand over to my learned opponent here, and I thank you all for your time.
We will hold all questions until the end.
Okay, let's go. Okay, so these are my disclosures. I am a physiotherapist. And this isn't about my job, this is about our patients. So why is Dr. Chilvers wrong? Or we could maybe say Mr. Wrong, and we need to ask people with CF to do airway clearance. First of all, we can't do a talk about modulator era without noticing that some people don't have access. And there are some people that are not eligible for modulators. So in an era of modulators, we still have a mixed population. We also have people who can't tolerate modulator therapy. So those people also fit into a box that they do not have that magic medication. And we know about adherence to therapies, right? This is a nice 2017 summary of adherence to therapies in CF. The therapy adherence was suboptimal. But surely, modulators, they're the magic drugs, right? Everyone's going to do those. Nah. Also suboptimal. And we have people on our ward who have dropped off of their adherence to their modulators for various different reasons, and they need airway clearance to rescue them, literally rescue them from intensive care, from ECMO, from transplants. So let's go back to the basics. Why do we do airway clearance? We know this, right? We've got a faulty CF gene, we've got abnormal CFTR, we've got that abnormal salt concentration, inflammation, infection, thicker sputum, and causing lung damage. And we know this is our, vicious cycle of CF with our airway clearance hits there. We're going to try and stop that airway obstruction. We're going to try and stop that lung damage and that increase in the inflammation. So I'm going to go through each of those bits. Obviously, Dr. Chilvers has done that very nicely already, but he's wrong. So let's just have a look at the data again, okay? So this is some data for 2019. As you can see, Dr. Chilvers was part of the team, so you'd think he'd know the data. I've put the line at normal. These guys are not normal. They're on ETI, but they haven't hit normal. Again, some nice data from 2022. The line's at normal. Again, there aren't many people under normal. And some nice data summarizing some of the other work on ivacaftor, lumacaftor, ivacaftor, tezacaftor, ivacaftor from 2023. The line of normal, how many people are under normal. So I would say sweat chloride, better, but it isn't normal. Sputum, normal or abnormal? So again, this is a study that showed the improvement of CFTR function and that you could see that sputum had gone down, and you can see that. More time on ETI, less sputum. But how many people here without a lung condition produce sputum? So any sputum, not normal. And this is something just from my PhD. We looked at, single session of airway clearance and how many people cleared sputum. And there was no significant difference between the amount of sputum cleared from people on or off of modulators. Both of them could clear sputum. And then you look at viscoelasticity. This is another nice study from Schaub and colleagues from 2023. You can see healthy is down here. Nobody hits healthy. So you've still got stickier sputum than you would from normal sputum. So again, sputum. Normal or not normal? Better, but not normal. Inflammation, normal or abnormal. So this is some nice data again, same study from Schaub and colleagues. These are various different measures of inflammation. Healthy is here on all of them, this dot at the bottom. And I think you can probably all tell, I know it's a little bit small, but none of those dots hit the normal. This one, purple's normal, purple's healthy. Post-ETI is here. It's not at the same level as purple. Green is still above, still more inflammation, inflammatory markers than normal. So again, better, but not normal. And lung damage, there's a lot of data out there, there's a lot of publications, there's a lot of writing about the fact that modulator medications are not thought to alter that existing lung damage, and that lung damage can also still start. Bronchial wall thickening, abnormal perfusion, peripheral mucus plugging, bronchiectasis. And I've got my colleague, Dr. Simmons, presented this in a paper recently, and he was saying, that bronchiectasis has improved with ETI. And it's true, A is pre, B is post, 2 different patients. But if you look at B, if someone in your clinic walked in with a picture like that, would you say that was normal? Would you say they don't have a problem that needs to have some airway clearance? Yes, it's better, but it's not normal. So infections, normal or abnormal? This is some data just showing people using healthcare after starting on ivacaftor from Mitchell and colleagues. And again, you can see it goes down with time on the medication, but it doesn't go to zero. This one, again, this is showing different infections, again, going down, but not zero. And this one here, so this is children over 6 years on ETI, and this is just their adverse events. You can see that Dr. Chilvers is on the paper, so again, he would probably know. And you can see that one of their main adverse events was a cough. And we know with CF, a cough often has some sputum and often means some sort of infection. So again, better, but not normal. So in summary, we have these, the ones in yellow, we have this problem. We still have all of these problems. They are not normal. So for me, airway clearance is still needed. So just, how about with the left trach? Is this the one that's going to make the difference? And this is just one paper that I've managed to find from Keating and colleagues. And it did say that it was superior to ETI in improvements in sweat chloride. But we saw in the plenary yesterday that graph, it wasn't at normal still. It's better, but it still wasn't at normal. And infective exacerbations in these studies were the most common side effect. So 32% of people on ETI and 28% of people on Aleptrec still had infections, infective exacerbations during this study. There are people still out there needing airway clearance. Better, but not normal. We don't know what the future holds. I hold my hand up. We don't know. We don't know the effect of ETI for a long time. We don't know what else is coming out there. We saw again in the plenary, there's other things coming out there. But what we have at the moment is quite a lot of data and real-world studies. I've seen some more this morning in a great study on the lung health about diseases progressing. Yes, it's still slowly, but, FEV1 is still declining. We're still getting lung problems. And we need to future-proof against that for our patients. We need to make sure that we're protecting them from decline in their lung health. Airway clearance, I think, is like backing up your computer. You don't notice that benefit until something goes wrong. And then you're grateful that you planned ahead. And it's really important to remember that. Another kind of analogy you can go with is preparing for a Seattle rainy day. Making sure that you've got that cover for you so that when you need it, you can grab it and roll on. So what about those standards that Dr. Chilvers mentioned? The first ones, physiotherapy advice for airway clearance should begin at diagnosis. Should begin. Physiotherapy for airway clearance should be individualized. We both agree on that. Absolutely. Let's individualize it. The second one, Dr. Chilvers is wrong. So he says that it doesn't mention physio at all, but it does. It says, builds on a framework of exercise and airway clearance, reinforces the importance of maintaining clean airways, even in an era of CFTR modulator medication. And funnily enough, Dr. Chilvers is on these standards. So, you'd think he'd read them, but anyway, we'll move on from that. Then we've got the question of the plenary yesterday, and again, lots of conversations have been had. Are we now treating non-CF bronchiectasis? And potentially, yes, we are, because if the CF defect is being corrected, potentially we've got this, different kind of disease. But then we're helped out by these really lovely new standards that have come out recently for the treatment of adult bronchiectasis. And it's got that very similar vicious diagram that we know about, that we've seen all the time in CF. And it's got airway clearance stonkingly large in there with 2 big ticks. And the 2 big ticks mean absolutely do it. Not many other things have 2 big ticks. Inhaled antibiotics, that might help somebody else later. But, that's what we're working on. And Dr. Chilvers agreed with this. This is a little leaked message from a little bird on my left. He felt this was so important that he needed to send it to his physiotherapy team. So, airway clearance is declining. I agree with this. This is actually a slide that I made for a different talk. I agree with you. It is going down. However, let's flip it a little bit, shall we? 96.9% in 2020 were still doing airway clearance, and 88.9% were still doing airway clearance. So yes, the number of people who are saying they aren't has increased. I acknowledge that. but we've still got an awful lot of people who are. And 78% of people on HERO 2 had not stopped airway clearance on enrolment. And I think that is our patient's voice. But then, the argument that Dr. Shivers gave us, people with CF don't want to do airway clearance. Do you know what? I've been a physio for 20 years in cystic fibrosis. I've had that a lot. And I know a lot of people in this room have as well. You come into the room, the patient hides under the cover, and they're like, I'm not here, I don't want to do it. And yeah, we're not all drill sergeants. We do have conversations with our patients, but we do know that airway clearance has always been not everyone's favourite. It's not sexy to spit in a pot, is it, right? And have someone watch you do it? Like, come on. But this is about being for our patients. What's right isn't always popular, and what's popular isn't always right. And we do need to remember that when we think about what we're advising for our patients. We have always worked with people with CF in partnership to create an airway clearance something, whether that is going for a run and doing a huff afterwards, whether that's doing your vest while you're, watching your kids playing, whether it's, AD while you do your ironing, whatever it is, we've managed to make something work so that people can do airway clearance. And I think for us, as a healthcare providers, we need to make sure that we remember that. We've always worked with our patients to individualize their therapy, and I think it's important that we do that now. So in summary, restoration of CFTR function by current modulators remains incomplete, and that's a lovely quote from the plenary yesterday. Whether we're treating CF or non-CF bronchiectasis, airway clearance is recommended, and we know that from all the standards. And we have a duty of care to our patients to ensure that we are proactively preventing that future lung damage, still trying to break that vicious cycle to make sure that the people with CF of the future do not have lung problems and lung damage. So I'm going to fall back on a summary slide from a book that was on the bookshelf when I started work at the Royal Brompton Hospital 20 odd years ago. Royal Brompton, or the Brompton Hospital Guide to Chest Physiotherapy. And the quote that I take from this is that chest physiotherapy must be a constant feature of CF management, even when the patient is apparently well. And I thank you very much for listening.
Round 1 complete. We're going to move on to round 2. Okay, it is now my privilege to introduce round 2 of our matchup, Gifford versus Donaldson. Our second head-to-head matchup brings together 2 heavyweight champions and CF legends who will present the pro and con arguments for the de-escalation of mucolytic therapies. From the city of the Browns, the Guardians, and the Cavaliers, Cleveland, Ohio, we welcome Dr. Alex Gifford. Dr. Gifford wears many hats, just a few of which include Director of the Adult CF Clinic or CF program at Leroy W. Matthews CF Center and Director of the Cystic Fibrosis Therapeutics Development Center at Rainbow Babies and Children's Hospital, where his work bridges the worlds of clinical care and cutting-edge research. Many of you will recognize Dr. Gifford's name from the Simplify trial, a landmark study that had the CF community watching, waiting, and ultimately reconsidering what the future holds. A seasoned clinician, researcher, and now debater, Dr. Gifford brings a deep understanding of CF care. We are honored to have him join us today to let us know if it's time to knock out mucolytics from the CF routine. In the opposing corner, stepping into the ring to defend the ongoing role of mucolytics in CF care is none other than Dr. Scott Donaldson. Hailing from North Carolina, Dr. Donaldson is a veteran heavyweight in the CF research arena and is ready to add some serious science to the debate. With over 25 years of research under his belt, Dr. Donaldson has spent his career studying the science of mucus clearance. A few highlights of his career: Dr. Donaldson serves as co-director of the UNC Adult CF program, and he directs the CFF's Mucociliary Clearance National Resource Center, where they're developing novel imaging biomarkers to visualize how mucus moves. Today, Dr. Donaldson is picking up the debate mic, hoping to convey one clear message. Even in the age of CFTR modulators, mucolytics still pack a punch. So please welcome Dr. Gifford first.
Well, I'd like to thank our organizers for inviting me to speak today and go head-to-head with the venerable Dr. Donaldson. So, food for thought question, Napoleon Dynamite. Just look at the caricature and think. Right. Disclaimer. Disclosures. All right. This is where we are. I want us to have a little fun with this and immerse ourselves in the courtroom setting. So, mucolytics are on trial right now. I'm the prosecution. So, this is our docket. So, we have Dornase alpha, hypertonic saline as the suspects here. Dr. Donaldson's defending them, and I'm going to try to set the stage by making a case for de-escalation of therapy. So, the defendant's counsel, Dr. Donaldson, would have you believe the following about Dornase and hypertonic saline. Point number one, the evidence base before ETI and VTD is the same as it is now. He's going to try to convince you that the simplified trial observations don't apply to your patients. He's also going to try to state that most people with CF actually continue to use these medications. And finally, you will hear a rather tepid argument that the medications are not especially burdensome. So we're going to poke holes in all this. So myth number one, the evidence base before ETI and VTD is the same as it is now. So these are data done in the era before both of these highly effective modulators. And in the first panel, you'll see a study done by Dr. Donaldson himself. Placebo-controlled trial looking at the effect of hypertonic saline therapy on FEV1. And we get, again, a rather tepid, paltry 4.7% improvement with hypertonic saline. Brief duration of therapy, or benefit, mind you. Then we look at the seminal study by Fuchs et al. About pulmazine, Dornase alpha. And so in the top curves, you see that there was about a 5.5 to 6% improvement in percent predicted FEV1 associated with the initiation of that mucolytic medication. But look at these data from the modulators, the highly effective modulators. So ivacaftor, the approval trial for individuals with G551D, 10.6% improvement. I don't think that the 10.6% improvement included the effect of the mucoactive agents, even though that was the standard of care in both arms. Also for ETI, so these are the data from the trial by Middleton and colleagues looking at ETI in F508del heterozygotes with a minimal function mutation. 14.3%. I had so much room to put that text under the curves. They're that far apart. I shudder to think that mucoactive agents had a contribution there. So, really, should we believe that the concurrent use of Dornase alpha or hypertonic saline during these trials contributed to such an improvement in FEV1? I think not. All right, next myth. Simplified trial observations don't apply to your patients, right? Try to convince you otherwise. So simplify. These are robust data, two parallel trials, same design. So during a 2-week run-in period of taking hypertonic saline or Dornase alpha, patients were ensured to be stable from a spirometric perspective and adherent to other therapies. Then, with the coin flip randomization, participants were assigned to continue hypertonic saline or discontinue in that study, and then in the other mucoactive agent in the other trial. There were some stratification parameters that allowed us to look at subgroups in a statistically appropriate way, and you can see those listed there. This is a figure of the primary outcome measure from Simplify. And what we're looking at here is the difference for both trials between groups that continued and discontinued each of the mucoactive agents. And a priori, we defined a 3% margin as non-inferiority. So if you think about this, if we had done this trial and there was a greater than 3% difference in FEV1 at 6 weeks, that would have meant that it's actually harmful to stop one or both of these agents. And then you can see here that there was no difference at all, even within the error. These groups were the same after 6 weeks. And so the conclusion we had was that discontinuing daily use of either medication didn't result in a meaningful change in lung function. So was my patient in Simplify, right? That's what you want to know. And with as much granularity as you can get with an individual in front of you and providing medical advice, I think your patient was in Simplify. So these patients are stable on ETI. They have either stopped or continued either of the medications. These are 20-somethings, 30-somethings. That's mostly the demography, just broad strokes. And their ppFEV1 going into the study was 97%, give or take. Let's look at registry data and see if patients really do look like that. So here I've superimposed the age of participants in Simplify plus the range around that. And if you look at the registry data, the percentage of individuals with lung function, it's 95, 70%. Those folks are Simplify participants. So I don't think that the case can be made for the fact that your patient wasn't in Simplify. In fact, most of your patients do look like Simplify participants. But the outlier, right? So Simplify was driven by a bunch of outliers. So if you look at these plots, they're called waterfall plots. They show individual responses in the outcome measure. There were curiously a mix of participants who gained or lost a small amount of lung function in either arm. But there was no difference between groups that discontinued or continued. So yes, there was variation in Simplify, that's expected, but it was really small and it didn't change the punchline. So outliers really didn't distort between treatment comparisons in the change in FEV1 and Simplify. Subgroup analyses. This is another way of looking at whether a subgroup drove the primary outcome measure. So we looked at differences between groups that continued and discontinued with respect to sex, baseline FEV1, use of other medications, genotype, infection pattern. You can see all these things here. And superimposed on the change in FEV1 is the non-inferiority margin, which again, in aggregate, we didn't come close to encroaching upon. And so you can see here that no subgroup was really driving the non-inferiority of discontinuing Dornase or hypertonic saline. So I think that your patients are or were represented in Simplify. Third myth. Most people with CF continue to use these medications. So Emily Granger and colleagues looked at data from the UK registry with respect to ivacaftor treatment. So there were 4 groups here. Before 2012, there were groups that were on a genotypic basis, eligible or ineligible for Dornase alpha, for ivacaftor. And these graphs show the proportions of patients who were using each of these medications. And so if we look at the group before 2012, when ivacaftor became available, there's no difference between in the proportion of patients who did or didn't use either of the medications. But something strange started to happen after we got on ivacaftor. We started to see a reduction in the proportion of patients who used one or the other of these medications. And ivacaftor, I would argue, is highly effective therapy like ETI. PROMISE gave us a similar insight into other medication use in patients who newly started ETI. And so in the left panel, you can see the magnitude, again, of the lung function improvement attributed to ETI in this group. And here were the concomitant medications. Over time, during the 6-month study, far fewer patients were using inhaled antibiotics, using macrolides, and then our suspects here, hypertonic saline and Dornase alpha, proportions went down during the study. We followed Simplify participants for 24 weeks after the study. We wanted to see whether there were a lot of changes in use or disuse of medications. You can look at it either way, depending on how participants were randomized in the trial. So there's a lot going on here. The top panel is for the Dornase alpha study, hypertonic saline studies in the lower panel. On the y-axis, we have participants reporting non-use. Okay, so we're looking at those who did not use either of the drugs. And so in the group of participants who we followed, who discontinued, were randomized to discontinue, over 50% were still not using anything. And the converse was true for the patients who were randomized to continue. And so the conclusion from the Simplify follow-up study was that in healthy people with CF on ETI, randomization was associated with greater odds of not using each medication after the trial compared to randomization to continue. Hero 2, we saw this with Dr. Chilvers. So these are data on use of concomitant medications during the first part of the study. So any discontinuations, you don't have to focus on the comparison between where participants were enrolled, but overall, any discontinuation, 41%. And if we look at Dornase alpha, 20%, and hypertonic saline, about the same 20%. So I would also argue that one criticism of Hero 2, even though investigators took steps to avoid this, is that this was self-reported use of therapies. So I suspect that a lot of patients said, yes, I am continuing to take my fill in the blank because I don't want to be viewed as being non-adherent or a bad person. So I think that the proportions here could be quite a bit higher in terms of the non-use of either of these meds. Finally, the burden argument. So in planning Simplify, we wanted to make sure that we were studying medications that were highly burdensome and clinically relevant as candidates for discontinuation depending on the results of the study. So we surveyed the patient and family community about their perceived burden of different therapies. So if we look at hypertonic saline, we saw that at least 81% of respondents, 89, give or take, thought that there was at least some burden attributed to hypertonic saline. And if we look at Dornase alpha, again, the biggest proportion of respondents thought that it was at least somewhat burdensome, and 11% said very. So that kind of stands in distinction to the not burdensome argument. Also, the Quest study, Qualitative Understanding of Experiences with a Simplified Trial. This study group looked at qualitative feedback from participants in Simplify. And overwhelmingly, the messaging was, we really liked not being burdened by doing these medications. Which is reflected here by this quote. So one of the themes that they uncovered in Quest was around intentionally reducing or stopping a treatment. After the Simplify study was done, I was able to drop half of my treatments. So before, I would do hypertonic saline and Pulmozyme once a day. Now I just do it every other day. And that was just one permutation of not doing it as much. So from this Quest paper, almost 3/4 of responses about decreasing burden described intentional reduction or stopping of treatments because they thought their health was stable and they wanted to feel more normal. Direct quotes. So I'm going to rest my case, and I hope I've convinced you that we should discontinue mucolytic or mucoactive medications. Thanks.
Thank you very much. It's been a great session. You guys really have put it together very well. Alex, great presentation. Very misguided, borderline deceptive at times, but double click, start. Okay, so yes, again, thanks for having me. I'm glad I get to go second. he can't respond to me. But I'll try to use this time to really correct the record of the evidence for continuing to use mucolytic therapies. So these are my disclosures. So before I jump into my arguments, just a couple comments, definitions, disclaimers. One, I don't really like the term mucolytic. What I really think about are really a class of drugs that improve mucus transport. So it might be a mucolytic like Dornase alpha. It might be something like hypertonic saline that speeds clearance. But I think it also pertains to novel therapeutics that we are developing for this exact purpose. So the arguments we're making today also should make us think about, do we even need to develop new therapies for people with CF1 modulators or not? I want to also make this disclaimer, not all people with CF are alike. So we're making, black and white arguments right now, but clearly one approach will not work for everybody with CF. A toddler or an infant with no bronchiectasis probably is not the same as an adult with bronchiectasis in terms of how they will respond to these therapies. Within an age group, somebody with mild disease is not going to respond the same as somebody with severe disease. A person with CF who produces sputum and is full of pseudomonas probably is not going to behave the same way as somebody who doesn't cough at all and has no pathogens. So that being said, the arguments that I'm going to make today will apply to people that have at least some detectable level of disease. So how do we decide with our patients whether to use these agents? So clearly, we need to listen to our patients' experiences and their priorities. This includes their current symptoms, what their past history, how did they respond to these therapies in the past, what the treatment burden is, we recognize that, and the impact of these treatments on their quality of life. And clearly, those things are going to be a major determinant of whether they actually use the therapies. Our job, however, is to really present the evidence to our patients that's available, along with their clinical experience, but we have to acknowledge the uncertainty when it's there. And in contrast to some of the things Alex talked about, we have to really focus on what I think are the key outcomes, and that is disease progression over time and the occurrence of pulmonary exacerbations, not just the blip in FEV1 comparing a modulator to hypertonic saline. And importantly, we have to do no harm as physicians. So in the absence of data, we have to consider the potential for harm if we tell somebody, yeah, it's fine, just stop all the things you've been doing. So this is what I'll focus on. So I want to review Dr. Gifford's case that he made, or the case he said I would make. So he implied that the evidence before modulator therapy was different than the evidence after modulator therapy. And actually, this is something we can agree upon. The problem, though, is we have very little data that is relevant in the post-modulator era. So that's a problem. Dr. Gifford said that simplified results are broadly applicable to your patients. Really? Okay, we'll get into that later. People with CF have already stopped their mucolytics, so why are we even bothering to have this discussion? Clearly, that's a gross generalization and quite nihilistic. And finally, mucolytics are burdensome. Again, we can agree upon that, but as Gemma said, there is a cost to benefit, and so these therapies may have a value that balances off the burden. So, do mucolytics work after initiating modulator therapy? So what's the evidence? So in the setting of using a mucolytic as an add-on therapy to modulators, really, there's almost no data. So we have to recognize that and realize we're in the dark in that regard. I will just reference this abstract, 139. It's a small clinical trial from Subasellers who looked at using dry powder mannitol as an add-on therapy to modulator-treated patients with moderate to severe disease. So take a look if you're interested. We do have evidence related to the safety of stopping therapies, however, that comes from the very nice Simplify study. I was also part of it. Love the study. There's problems, though. The period of intervention was a 6-week period. This is far too short to predict any impact on future pulmonary exacerbations or lung disease progression, which are, I think, the key endpoints we have to keep in mind.
Further, although Alex claims that your patients all have 97% lung function as well, we know that's not true. He focused you on that 18-year-old who has very good lung function, but those are not the only patients we take care of. We know from the 2024 registry that the median FEV1 in an adult is 83%. That means half of your patients are worse than 83%, and a vast majority of your patients are worse than 97%. So clearly, especially on the adult side, our patients have disease, and that does not look like the population in Simplify. We've mentioned these great studies. We're very thankful that they're coming. We've seen some of the data from HERO 2 already. Tomorrow, I'll just point you toward the CF Storm presentation and workshop 32. Looking forward to that. But clearly, more research is needed. So it might be very easy when you're sitting in clinic and talking to your patients to really get into a mindset, CF lung disease is already fixed. Why should I press my patients and be the drill sergeant and ask them to do these things that are not easy? So why might mucolytic therapies actually be of value? So you're likely familiar with this vicious vortex that describes the progression of lung disease in CF and non-CF bronchiectasis, where abnormal mucus clearance allows bacterial infection and colonization, which in turn drives neutrophilic inflammation in the airways, which ultimately is what's responsible for the progressive destruction of airways. Now we know highly effective modulators are awesome, but they're not perfect. So if this vortex actually still persists after modulators, why would we not treat it? So we have a lot of data that tells us that this vortex does persist. So this is from the PROMISE microbiology study presented by Dave Nichols in JCI a couple of years ago. Certainly, the density of bugs in sputum drops markedly after initiating modulators. But as this graph shows, that the percentage of patients who have a positive culture for staph, pseudomonas, or other classical CF pathogens really doesn't change over time. So infection is less intense, but it persists. Now, the worry is if you have persistent infection in your airways, that is going to drive persistent inflammation. And clearly, this is the case. So this is from Annals ATS paper this year from Scott Sagal. This was from the PROMISE inflammation substudy. And what the data that I'm showing you here on the left is sputum neutrophil elastase activity. And on the right, sputum IL-8 activity. And clearly, when you start a modulator, these things do improve. But over the course of 24 and even 30 months of therapy, it does not normalize. The blue bars at the bottom is what normal is. So clearly, we are still well above normal. So we have infection, we have inflammation, and the concern is this going to drive progressive lung disease? Well, we get our first glimpses of this actually from old data after the approval of ivacaftor. Greg Zawicki showed us the impact of ivacaftor in patients with G551D CFTR mutations, and that indeed this was a disease-modifying therapy. So it slowed the decline of lung function loss over time, but it did not stop it. And that's the key point here. We know from additional work that came out a few years later using the Irish CF patient registry that in kids with CF who started out with very good lung function, they did pretty well. So over the 3 years of post-treatment observation, they did not appear to lose much lung function. But look at the adults in the blue line at the bottom. We see that these patients who had much worse lung disease, after initiating therapy, they continued to lose lung function over time at a pretty substantial rate, 1.7% per year. So what about ETI? ETI is not ivacaftor. There's certainly good evidence that it probably is a more effective CFTR modulator. And this paper was just came out in print this month in the Blue Journal from Corey Daines and for the investigators on the open label extension after the phase 3 study of ETI in patients with at least one F508 del allele. And this is striking. So that top blue line is the treated patients for 4 years, and they did not see any loss of lung function. So I should just walk off the stage now and just give up, right? Well, a couple things. Alex made the point that other therapies just don't matter, but these patients were not using ETI alone. They were also using other therapies. So to get this miraculous result, they were doing other things as well. And so 84%, at least at the start of the study, were on Dornase. 71% were on hypertonic saline. But I think an even more important point to make is that patients who enter interventional clinical trials oftentimes don't get the same results as patients who walk into your clinic who are not in clinical trials. And so let's see what other data might be there that can tell us what your patients in your clinic might, how they might do. So this comes from the PROMISE study, courtesy of Marty Solomon. In this study, the trajectory of lung function before starting ETI was compared to the trajectory of lung function after ETI. So there's a 30-month pre-ETI period and between 30 months and 4 years after ETI. We looked at the data in different age cohorts, so between 6 and 11 years old, 12 and 17, and an adult cohort. The common theme is that in each of these, there is a negative slope to the data. So patients are losing lung function over time. And in fact, the slope of lung function loss after ETI was pretty much identical to what it was before ETI. And in fact, in kids, it was worse. So this is concerning. What about even more real-world data? So this comes from the Longitude study, which is a study performed using the UK patient registry. In the study, they looked at lung function decline over time as well as exacerbations. And we can see that now in thousands of patients that indeed adding ETI improved the loss of lung function over time compared to historical modulator naive patients, but it didn't stop it. So we see that still patients are losing lung function at a rate that we should be concerned about. What about the effect on exacerbation? So yes, modulators reduced exacerbations, but this is not anywhere near zero. So we went from 1.4 per year to half per year. These patients are still having exacerbations. And if we total up the number of IV antibiotic days over the year, we went from 36 days a year, a tremendous burden, to 19. 19 days of IV antibiotics is not fixed. Okay, so nobody's using this stuff anyway, so we should just forget about it. Well, this is where I think things are a little deceptive maybe in the prior talk. So we'll go back to the same slide that Alex showed. Okay, so this is, in the simplified study, people were randomized to using or not using Dornase alpha and hypertonic saline, and then they were left to their own devices for another 24 weeks. We didn't tell them to restart their therapy. We didn't tell them not to restart their therapy. We just saw what they did, right? And so as Alex correctly pointed out, in patients who are randomized to stop, they had a greater tendency to continue not to use the therapies afterward. But let's look at the numbers, okay? In those who are randomized to stop Dornase, they had 6 weeks to experience the freedom of not using the therapy to see how they felt. Well, what did they do? Well, 44% of them restarted the therapy on their own. In the hypertonic saline study, 63% decided to restart the therapy on their own. And remember, these are patients who have near normal lung function. Okay, and we know that there's a relationship between how sick you are and your likelihood of using therapy. So this is a very model group who are making the decision and voting with their feet to use these therapies. So I think it's incorrect to say that patients are not using these therapies and don't want to use these therapies. And the groups who are randomized to continue therapy, they continue to use it more than 85% of the time, more than 85% of the patients. Dr. Gifford also brought up the incidence of mucolytic discontinuation in HERO2, and so this is this study enrolled 2 to 3 years after the availability of ETI, and he focused us on the 41% who stopped at least one thing, but in fact, only 1 in 5 people stopped hypertonic saline, only 1 in 5 people reported stopping Dornase alpha, so 80% continued. Now, this is a little complicated because they recorded reports of discontinuation. They didn't record, are you using? Okay, so we are making some guesses, but if you believe that this patient population roughly reflects the CF, the larger CF population, at least 50% of these people are continuing to use these therapies. So, in summary, we have imperfect data. We need more data. But in the meantime, we cannot do harm to our patients by telling them everything's fine, stop. I think I've shown very clear evidence that lung disease persists after the initiation of modulators, and in real-world patients, it progresses. And so we should continue to offer therapies to find better treatments and try to maximize long-term outcomes. So with that, case closed. Thank you.
Okay, I have the pleasure of introducing our third and final round, oats versus vote. And our final set of presenters will be taking a jab at anti-pseudomonal therapies. Pseudomonas is a known enemy of the CF lungs, so we would be remiss if we did not also take aim at this villain. To examine the two sides of the argument, we brought in some champs from the pharmaceutical world. First up, Margaret Oates will be stepping in to argue in favor of de-escalation of inhaled anti-pseudomonal therapies in the HEMT world. A graduate from the University of Kentucky's PharmD program, Margaret is bringing to us her deep clinical knowledge and sharp therapeutic insight into this high-stakes discussion. Margaret has worked on the front lines of the team at the Children's Hospital of Georgia, where she's been combating CF bugs with drugs since 2019. From mentoring future pharmacists to shaping antimicrobial stewardship strategies, Margaret is hands-on in every aspect of pediatric CF pharmacotherapy. With this firsthand knowledge, Margaret is here to argue that in an era where highly effective modulator therapy is changing the game, it's time to ask whether our old anti-pseudomonal routines still make sense or whether less might actually be more. And last, but certainly not least, we will then welcome Hilary Vogt, a clinical pharmacist and formidable opponent, to our debate stage. Racing in from the home of the Indianapolis Motor Speedway, Hilary will bring precision and endurance to this conversation. Hilary works as a pulmonary clinical pharmacist at Riley Hospital for Children, where she supports the pediatric CF team with her expertise and unwavering commitment to patient care. Before shifting her focus to pediatrics, Hilary was an adult CF clinic pharmacist, which gives her a unique perspective of the lifespan of CF care. Today, Hilary will bring a thoughtful but patient-centered approach to the question of the de-escalation of anti-pseudomonal therapies. Her arguments will speak to the complexity of this issue and the care that's required while rethinking long-standing treatments. Her efforts reflect the battle against Pseudomonas that we continue to fight, one inhaled nebula at a time. While change might be inevitable, Hilary will remind us that in the future of CF care, we must be guided by both optimism and vigilance. So first of all, we'll welcome up Margaret. Thank you.
Yeah, and I trained her, so I'm not really sure how I'm in support of your argument here. So I do not have any relationships to disclose related to this presentation. During this section of the pro-con debate of inhaled anti-pseudomonal therapies, Hilary and I will critically assess the evolving role of inhaled antibiotic therapies. We'll review the evidence of antimicrobial resistance and inhaled therapies, and lastly, we'll explore their impact specifically on patient outcomes and healthcare utilization. So I'm just going to start off brief overview of our current standard of care recommendations and evidence-based guidelines for inhaled antibiotic treatment utilization. I think all of you know that chronic Pseudomonas has been associated with faster lung function decline and more frequent pulmonary exacerbations. Our inhaled antibiotics have historically been essential to reducing that bacterial density, contributing to the pulmonary exacerbations that our patients experience. And standard of care really favors long-term cyclic inhaled antibiotic therapy. But as previously mentioned, this model may not fit all patients, particularly in the highly effective modulator therapy or HEMT era. So inhaled tobramycin, either nebulized or as a dry powder, and ace-trionam are really our most common antibiotic agents used. They're typically cycled in a 28-day on and off cycle approach. And for years, the rationale behind continued cycle therapy was suppression of the bacterial load and ultimately a reduction in pulmonary exacerbations. However, chronic use does carry a significant treatment burden, as we've already shown in previous studies, particularly what our patients perceive, and they may actually drive antibiotic resistance. So I think these challenges are both becoming increasingly more relevant. So just to outline, as I move into the debate portion of this presentation, I want to highlight the 4 key arguments as it relates to the pro perspective of de-escalating inhaled anti-pseudomonal therapies. So these, my arguments will include the maintenance of clinical stability due to highly effective modulator therapy, emerging resistance, and the role of antimicrobial stewardship, reducing treatment burden for our patients, and ultimately the quality of life, and also economic stewardship. So HEMT, which includes elexacaftor, tezacaftor, ivacaftor, or ETI, has been shown to significantly improve airway clearance, pulmonary function, and reduce inflammation. Furthermore, clinical data showed that ETI decreased bacterial burden and pulmonary exacerbation rates, prompting the question in this era of ETI, do patients still need these inhaled antibiotics? In a French cohort, patients on ETI had a 56% drop in IV antibiotic use with improved clinical stability, and US pediatric data showed a 40% reduction in inhaled antibiotic use without increased pulmonary exacerbations. I think this is promising real-world data that de-escalation of inhaled anti-pseudomonal therapy is both safe and effective, particularly in the post-ETI era. In the literature surrounding antibiotic resistance has shown that repeated antibiotic exposure can exert what we call selective pressure for resistant strains to develop. Specifically, resistant strains of Pseudomonas aeruginosa have been increasingly reported, and we often see this trend in the sensitivity reports of subsequent CF cultures that are obtained. Furthermore, antibiotics can wipe out beneficial bacteria, particularly in our gut, along with the intended bacterial pathogens, which disrupts our microbiome. This microbiome disruption contributes to a loss of diversity and the ability for dominant resistant pathogens to emerge and colonize. It's been long thought that inhaled antibiotics don't carry the same risk as systemic antibiotics. However, I would argue chronic suppressive inhaled antibiotics can still contribute to the utilization of greater systemic antibiotic use. And really, there's just limited data to show that inhaled antibiotics don't have the same associated risk. Patients also, as we've mentioned, are likely not as adherent to these therapies anymore. So when we are not using antibiotics in their intended mechanism, so utilizing it only once a day versus twice a day in the case of our inhaled antibiotics, or having inconsistent use with their inhaled anti-pseudomonal therapy, I think that needs to be a consideration for the contribution for resistance formation. And ultimately, our goal should be to do all that we can to minimize resistance development due to clinical consequences that can include treatment failures and less future treatment options for our patients. So antimicrobial stewardship in CF, I think it gets a bad rap, but really it's not limiting use. It just means tailoring therapy to the patient's current risk, not historical practice. The focus of utilizing antibiotics should be on precision and balance, leveraging our team-based approach to care and the data and tools we have at our disposal to guide antibiotic use. So although aerosolized delivery can offer our ability to achieve higher concentrations at the site of action, these therapies are still not without their risk and associated toxicities. There's plenty of data to show that even using an inhaled form of an anti-pseudomonal can cause hearing loss and even increases in a patient's serum creatinine. Additionally, in 2023, an analysis utilizing the European CF patient registry data revealed no benefit in those receiving treatment with inhaled antibiotics without Pseudomonas infection. Overall, in a time where we have less novel antibiotic therapies in development and we have increasing resistance that is constantly reported, I think it's time to rethink the one-size-fits-all antibiotic approach and strategies, including how we approach chronic suppressive inhaled therapies, so we can preserve our available treatment options. This has also been mentioned before. It's well known that patients with CF have a significant treatment burden at baseline with their just standard treatment therapies that we ask them to do, so not including their inhaled antibiotics. Daily inhaled therapy often consumes up to 2 hours and involves multiple devices when inhaled antibiotics are involved. It's also well documented that the higher the treatment burden, the higher the reduction in adherence, leading to poor outcomes. Eakin and colleagues demonstrated that poor CF medication adherence is a significant predictor of having a pulmonary exacerbation during a concurrent 12-month period. Their results highlight the importance of medication adherence on patient clinical outcomes. De-escalation of inhaled antibiotics can also allow for improved quality of life measures because of the reduction in treatment burden and ultimately an improvement in adherence. Sawicki and colleagues reported that daily treatment activities and perceived treatment burden was high in all adults with CF, regardless of age or their disease severity, and specifically increasing the number of nebulized therapies and increased airway clearance time was associated with higher perceived treatment burden, which I think really illustrates the need to evaluate the effects of high treatment burden on our patients' quality of life and to increase efforts to try to lower that treatment burden. In addition to the quality of life costs to the patient, practically speaking, there's an economic burden of inhaled antibiotics, and it's not benign. The cost of cycled inhaled therapy itself, excluding all other indirect costs, is estimated to be about $5,000 per treatment cycle. Indirectly, patients receiving inhaled antibiotic therapy may incur additional costs in terms of equipment needed, caregiver time, and overall cost to the healthcare system in terms of the downstream effect of drug therapy that may be prescribed both inpatient and outpatient when we know patients are also on cycled inhaled therapy. De-escalation of inhaled antibiotic therapies may reduce costs without compromising care quality, which has significant implications for the health system, for payers, and for patient families. So just as a practical example exercise, this is a fictitious patient we're going to take a look at. So this patient, we'll call her Emily. She's a 14-year-old patient with cystic fibrosis. She's homozygous for F508del. She's been on ETI stably for 9 months. Her FEV1 has improved by 12% since she started on ETI. She hasn't had any pulmonary exacerbations for the last year, but despite this remains on cycled ACE tree-and-am because of a history of pseudomonas colonization. So I'm just curious, poll to the group, show of hands, who would consider this particular patient as maybe a good candidate to discontinue her cycled ACE tree-and-am on? And then who would not? Okay, so aside from that girl in the front, most people I think I saw said that they would stop. So I think when considering suitability, I consider these to be the 3 pillars to take into consideration. So clinical stability of the patient. Is the patient on highly effective modulator therapy? Have they been without any recent pulmonary exacerbations in the last 6 to 12 months? What does our culture data show us? We know that not all cultures are created equally. Hillary's going to try to skew you way off on a pathway there. But has the patient had good follow-up with objective data that shows that they are culture negative for Pseudomonas? And their lung function trajectory. Is the patient able to perform reliable spirometry where you'll be able to see stability or improvement or maintenance of that baseline? Overall, I think it's bringing home the point that the clinical picture of the patient, not their culture data alone, should guide our decision-making. So just bringing it back to Emily, I think just to highlight here for me these 3 pillars, I think that she would be a perfect candidate to have that discussion about anti-pseudomonal therapy de-escalation. We at our institution developed criteria for a systematic de-escalation or step-down of inhaled anti-pseudomonal therapy. For all patients who have not cultured Pseudomonas in 2 years, we automatically de-escalate their inhaled anti-pseudomonal therapy regardless of being on highly effective modulator therapy. And then patients, if they're culture positive but without an exacerbation in 6 months, or culture negative for 6 months but on continuous, so have no breaks in an on-off cycle, and stable on highly effective modulator therapy for at least 3 months, We either transition them to every other month cycles, or then again, if they're alternating between two agents, have one that is discontinued. And then after 6 to 12 months without inhaled therapy, patients additionally that are on azithromycin will also have their azithromycin maintenance discontinued if they remain culture negative. We do closely monitor these patients for symptoms indicative of a pulmonary exacerbation. We follow their spirometry and cultures, and we tailor our approach based on the patient's response. So as we look to peel back and de-escalate therapies, the concern is the clinical decline that the patient may face. And I do want to underscore this is a very real concern, but I also think that de-escalation should still be a consideration with appropriate mitigation strategies. Risk can be mitigated by ensuring close culture follow-up and rapid reinitiation protocols. As previously mentioned, I think the overall clinical picture needs to take priority. We know that once patients culture Pseudomonas, eradication can be difficult and colonization is likely, but we also know colonization does not equal active infection or necessitate the same treatment strategy. It's important to prioritize clinical context, even in light of a patient who continues to culture Pseudomonas. And lastly, imaging can be helpful, I think, to assist in early detection of infection or subclinical changes, helping us to fine-tune or modify our treatment approach before concerning symptoms develop. So the idea of partnership and shared decision-making, they're not novel concepts, but they are routinely being discussed now more than they ever were before. And this partnership between patients and caregivers and the team is essential. When we're assessing goals, making treatment plans, and identifying barriers to treatment adherence, we must engage and partner with our patients and families. Our therapy plan should align with their goals and ultimately optimize their quality of life. In my opinion, all treatment approaches are risk versus benefit analysis. Our job as clinicians is to provide education and our professional analysis of the treatment options. When we think about de-escalating inhaled therapy specifically, we can outline the contingency plans for re-escalation, pending patient response, documenting our plan clearly, and including re-escalation triggers. So to summarize, in conclusion, CFTR modulators, specifically highly effective modulator therapies, have reshaped CF management and how we interpret and apply recommendations for standard of care respiratory therapies. Ultimately, in a high treatment burden disease state, in a world with increasing antibiotic resistance, this new era focuses us to reevaluate the necessity of chronic suppressive inhaled therapy. De-escalation of inhaled antibiotic therapy appears both safe and effective as part of a collaborative patient and care team decision approach that encompasses mitigation strategies to adjust based on individual patient clinical response. That's it.
All right. Thank you all for being here today. I have no real disclosures except for to say that Margaret and I don't know the women in those AI photos. So to close out today's pro-con debate on therapy de-escalation, I will talk about why we should not be de-escalating anti-pseudomonal therapy for people who have been positive for Pseudomonas aeruginosa. And my argument will be based on the following points. 1, we need to maintain the health advantages that we have gained by highly effective modulator therapy in addition to the maintenance therapies we were already using. 2, there is limited data connecting inhaled antibiotics to antimicrobial resistance. 3, we have a lack of robust culture data for patients on highly effective modulator therapy. And 4, the possible cost savings of de-escalating therapy could be offset by the potential for lung function decline and increased pulmonary exacerbations. So my goal is to break down what we actually know in our evidence that we have and what we don't know yet, so that we are not just basing our clinical recommendations on what we hope to find in the future. So while I'd love to safely de-escalate therapy and relieve the treatment burden for our patients, we just don't yet have the data to prove this is the best choice for the majority of people living with CF who have had Pseudomonas. And just remember, Margaret taught me everything I know. So we do know that there were substantial health benefits seen in the highly effective modulator phase 3 trials, but we have to keep in mind that the majority of the participants in these studies actually continued their maintenance therapies, which included inhaled antibiotics throughout that study period. So what this looks like is for the F508 the Hetman phase 3 ETI study, 59% of the ETI group was also receiving an inhaled antibiotic. And for the homozygous F508del study, 64% of people in the ETI group continued their inhaled antibiotic. So importantly, these are the trials that showed the substantial reduction in pulmonary exacerbations and about a 14% improvement in lung function. But what these studies don't tell us is what happens if those individuals then stop their inhaled antibiotics, because we know on their own the inhaled antibiotics make a difference in both of those clinical outcomes. Another thing we know from many years of data is that anti-pseudomonal antibiotics are safe and they're well tolerated by most people. So there is some individual tolerability differences, but in large meta-analyses, the only adverse effects that were conclusively seen to be more common than placebo were voice alterations and tinnitus. So importantly, when we're using the inhaled delivery route specifically, there's no long-term connection with changes in renal function or hearing loss, which are always key concerns with the inhaled aminoglycosides. Next, I want to highlight the lack of evidence connecting inhaled antibiotics to antimicrobial resistance. So yes, my general approach would be to de-escalate antibiotics for the sake of stewardship, but I'm really not sure that that risk outweighs the benefit outweighs the risk when we're talking about de-escalating inhaled antibiotics. So really, I want to make the distinction here. I'm talking specifically about the inhaled route of delivery, and that's an important factor to consider given that the goal of using the inhaled antibiotics is to reduce exacerbations with treatments like highly effective modulator therapies and the antibiotics. So if we are doing that at the expense of more exacerbations, that's going to necessitate the treatment for more oral and IV antibiotics, and those do have data contributing to antimicrobial resistance. So one such study by Kojan and colleagues observed no increased acquisition of any new organism when using inhaled antibiotics. This was in children participating in the EPIC study. So that was people with new pseudomonas acquisition who received either 18 months of cycled inhaled tobramycin therapy versus culture-based therapy, and they were just started on inhaled antibiotics during that treatment quarter that they cultured positive for pseudomonas. Those patients were followed for a 5-year observational period, which I think is pretty impressive, and that's when they showed that there was no increased risk in acquisition of new pathogens during that time. They did show an increase in Achromobacter acquisition in people who just received even 1 week of oral antibiotics, and they found an increased risk of multi-drug resistant Pseudomonas with IV antibiotics. And this is the whole thing that we're trying to avoid here. So additionally, the most recent Cochrane review of inhaled antibiotics, which is periodically updated, last was in 2022, they showed no effect on Pseudomonas density, no increased acquisition of other pathogens, and no change in MIC to active antibiotics when inhaled antibiotics as a whole were compared with placebo. So changing directions a little bit, but still with the theme of things we don't know. Respiratory cultures. So unfortunately, highly effective modulator therapy has come with the consequence of a lack of sputum for us to culture and collect data on. We're obtaining less expectorated sputum, more pharyngeal swabs, and less overall cultures per patient than what the CF Foundation recommends. So that longstanding recommendation has been 4 cultures, sputum cultures per year. And we all know that adherence to that recommendation dropped significantly during the COVID-19 pandemic, but it's still only returned to an average of 2.8 cultures per year as of the 2023 CF patient registry report. So at the time of that report, only a third of patients were adherent to that recommendation to have 4 cultures during the 2023 calendar year. What this tells me is that we have even less data and evidence to base our decisions to de-escalate on. We also know that even good quality culture data and expectorated sputum doesn't always represent the entirety of the lung microbiome, as was discussed in yesterday's plenary session. So my concern is that given these limitations, we might be inclined to de-escalate therapy thinking we don't have evidence of Pseudomonas, but what we really don't have is the right evidence to be basing that decision on. Plenary 1 kind of stole my thunder on this, but should we even be expecting to clear or eradicate Pseudomonas at all? We will have individual patient considerations that we know can impact that. So how long have they been positive for things like Pseudomonas? What the bacterial burden is, with the suspicion that people who have had longer standing chronic infection or higher bacterial burden are less likely to clear. But most studies indicate that the majority of chronically infected Pseudomonas cannot be cleared or eradicated. So Armbruster and colleagues collected sinus, throat, or sputum swabs from 19 adults living with CF before and after they started ETI. They found that people on ETI had a reduced Pseudomonas burden, but they did not achieve eradication in 18 out of those 19 participants. So when they looked a little deeper, they also studied 7 of those 19 people who had Pseudomonas and found that this was the same strain of Pseudomonas when they did a microbiological assay. So this is not just an unlucky new acquisition of Pseudomonas or a new infection. It's that Pseudomonas just did not go anywhere when they started ETI. Next, we have the PROMISE micro study. So these are just preliminary results, I believe, at the 3.5-year mark. But following micro outcomes of 177 people, they found that Pseudomonas aeruginosa prevalence did decrease at the 1-month mark on ETI therapy. That was by almost 25%, which is great. But over the rest of that 3.5-year time period, that burden did not reduce further. Additionally, there were almost 12% of people in the PROMISE micro group who were previously Pseudomonas negative, who cultured positive at least once during their study period. So this just demonstrates the need for ongoing culture collection, really making sure we're not overlooking acquisition of new pathogens. So while ETI is newer and this data is a little bit more recent, it tracks with the prior studies we have on ivacaftor for this as well. The G551D observational AL study, or the GOAL study, was an observational trial for 151 people who were over 6 years old with a G551D mutation. This was done at TDN sites, and the participants were all new initiation onto ivacaftor, and they looked at them 1 year before and 1 year after starting. They collected their data from the CF patient registry and found that mucoid and non-mucoid Pseudomonas presence decreased at the 1-year mark on ivacaftor by an odds ratio of 35% when compared to the year prior to ivacaftor. But when looking at mucoid strains, 27% of participants were Pseudomonas free at 1 year, but there was no difference at 2 years. This study also looked at a lot of different little groups. They had really a lot of interesting findings with dividing people out between being Pseudomonas free, having intermittently positive cultures, or persistent infection. Persistent was more than 50% of their cultures being positive for Pseudomonas. And one result I want to highlight from that group is that for people who had 3 or more cultures in both the year before and after ivacaftor, only 7% of participants with persistent infection actually cleared their Pseudomonas. This data is consistent with data from Dr. Heisert and colleagues that was published in 2017. They prospectively followed 12 adults with CF and at least 1 G551D mutation who started ivacaftor. 8 of those people were persistently positive for Pseudomonas. And they showed a 10-fold reduction in Pseudomonas colony-forming units at day 7 of ivacaftor therapy. And that reduction continued over the first 7 months on ivacaftor, but none of their patients became culture negative. Then in the second year of ivacaftor treatment, that Pseudomonas colony-forming unit count began to increase again, nearly to pre-treatment levels throughout that time. So this was another study that completed the microbiological analysis, confirming this is the same strain. It's not just a new acquisition of Pseudomonas over the course of the study period. So again, we're just not getting rid of that. So my point here is not to be such a pessimist about the chance of clearing Pseudomonas. I just think it's important to think really carefully before de-escalating, given the data that the majority of people will not achieve clearance of Pseudomonas. It's just really important to consider how much culture data we have, the quality of that data, and patient-specific factors like how long they've been historically positive for Pseudomonas. So because we know the risks of these chronic pseudomonas infections, we know the risks that are associated with the chronic inflammation it causes and the correlation with lung function decline. I think that given all of that, we really need to consider the risks of treatment discontinuation carefully before assuming that something is not there. Lastly, a bit reluctantly, because I try not to base the majority of my clinical decision-making on cost, we unfortunately do have to consider that though. I believe the cost of stopping an anti-pseudomonal antibiotic in many cases can be offset by the cost of increased pulmonary exacerbations or other worsened pulmonary outcomes that can also be very costly. So as Margaret stated, the cost of inhaled tobramycin suspension is about $5,000 per month, and many people do that every other month chronically. But the cost of even an outpatient pulmonary exacerbation is substantial. So way back in 2017, so long ago, the cost of that was thought to be about $12,000 on average for a pulmonary exacerbation. We can all assume that that cost has probably gone up even further in the last few years. I was also surprised to see a 2023 study looking at annual costs of pulmonary exacerbations. When they found the cost of a severe pulmonary exacerbation for patients, it was about $120,000 per year. And then even for a mild exacerbation, it was over $30,000 per year. So with these costs to our healthcare system, it likely does make sense to continue to use our maintenance therapies to avoid outcomes like pulmonary exacerbations by using our maintenance therapy. So in summary, we currently have no data on the safety of discontinuing anti-pseudomonal therapies for people who are taking highly effective modulators and have been positive for Pseudomonas. We also know that culture data is not always an accurate indicator of the presence of Pseudomonas in people taking highly effective modulator. So at this time, the safe and conservative approach is to continue anti-pseudomonal therapies to maintain the significant health benefits that we've seen from highly effective modulators. Of course, we have a lot of information we're looking for in the future. So one really important thing is going to be to collect data on de-escalation as a CF community so that we have some robust prospective information on this topic. I think it's great that people are doing individual institutional protocols to kind of standardize this approach, but we really need to have a bigger collection of data. We also need to determine the most accurate way to culture and collect microbiology data and study how Pseudomonas adapts over prolonged periods of time to highly effective modulator therapy, and then how that inflammatory response adapts as well. We need to, most importantly, continue to balance quality of life and patient preference with prioritizing really, really high achieving clinical outcomes. So we will take any questions with the Q&A.
Okay, let's give one more round of applause for our speakers. What a great debate. Before we take questions, we wanted to post some concluding thoughts. Once again, we revisit these three long-standing historical pillars that have stood the test of time in upholding the battle for the preservation of CF lung health. Oops, sorry. Oh, no. Okay. After hearing our experts make punches either for or against these ancient pillars, we're starting to see some cracks develop. But we must carefully examine these cracks that are forming. The questions remain: are these pillars going to remain standing over the test of time, or will they crumble to the ground? Only time will tell how the foundation stands and what will become historical ancient ruins or what will continue to stand. We know that not all people with CF are the same. We also know that this foundation is shifting and the landscape continues to change, which we shouldn't be afraid of, as we know that the only constant is change. Ultimately, this does make us better and stronger. And while our speakers each argued their points with conviction, this era more than ever underlines the importance of personalized medicine, which we've always done, but we're being asked to expand maybe to a point outside of which we may be comfortable. Before we had pretty conclusive guidelines. Now those are widening and loosening. So to include all the factors that influence the clinical care we provide, we must consider the age at the modulator start, their current clinical status, their current age, the current stage of their lung disease, their current modulator status, their genetics, their lung function, their response, their current structural lung disease, any comorbidities, their current microbiology, their adherence, their social situation, and their coverage resources. So this is quite a lot to incorporate as we consider each individual patient. So we'd like to revisit this same survey that you took at the beginning of the, oh, that one. Okay, there's the QR code. It's the same question that we asked you to take at the beginning of the session, and we have the numbers that we started with. So we wanted to see, did our debaters change any of your minds? And we will take questions at this time. You can put them through the app or please come to the microphone.
So the first question in the app comes for our airway clearance presenters. So the question is, what about a compromise as needed use of airway clearance? Maybe both of you or one of you can come up. How about both of you?
Yeah. Yeah, you completely, hit the nail on the head. I mean, I think we've both said it. It's that compromise. It's that, as and when, as needed, you're not going to work with a patient and stand there and go, you are doing this every single day, twice a day for 30 minutes. It doesn't work like that, does it, at all? Patients are just going to come back at this and not be doing anything. So yeah, it's definitely that compromise and what works for the person. What's the best technique? What's the best time? So yeah, definitely a compromise.
I agree.
Okay, thank you so far, yes. Okay, for our pharmacists. Oh, sorry.
Oh, no, you could do that one, Chris. Chris Syracuse of Cincinnati Children's, that was a great session that you guys organized. So thanks for doing that. And it's a lot of fun. And this is more of a general question and anyone could feel free. We brought up personalized medicine, shared decision making, which is super important. I think when we are also thinking about pediatrics, though, there's an added level of responsibility to make decisions for children that can't make decisions for themselves. And in that vein, does that potentially shift the conservativeness in which we make these recommendations? And I also, worry that de-escalation soon becomes don't start to begin with, then we can't even apply this data at all to those types of decisions. So I'm just wondering if anyone has anything to add from a pediatrics lens. I know there's a lot of adult people up here. But.
We have adult people with some pediatric experience.
Yes.
Do any of you care to comment?
I think it's good standing, yeah. I think the microphone is being recorded. Oh.
Hi, it's Alex Gifford. It's a good question. I mean, I am an adult pulmonologist, preface everything with that. But I mean, whether to initiate, right, is huge right now because we have highly effective therapy creeping down to younger and younger ages. And, I think what might offset the desire to not initiate and wait is, is my child going to tolerate the modulator as we learn more about side effect profiles and everything. So it's complicated. And there's the dyad, right? The parent and child dyad to navigate. So I think it's probably harder than what I talk about every day.
Yeah. And we saw that in Quest too, that when we would interview parents and adolescents about, in the same dyad, that they had different answers to things about burden and things like that too.
Mm-hmm. Good questions.
Okay.
For Margaret and Hillary, our pharmacists, what are your thoughts on utilizing anti-pseudomonal therapies when feasible during periods of exacerbations so as to limit the use of IV aminoglycosides in the light of concern for antimicrobial resistance?
I think I interpret that question as instead of using the IV, patients getting, needs to be treated for a pulmonary exacerbation, so you want to use it inhaled. Hopefully I would get that question correct. I think that's probably reasonable. I think there are challenges sometimes in terms of, is this an outpatient or an inpatient exacerbation? I think for outpatient, we've definitely utilized that at our center, or tried to say, okay, well, I know you maybe are, like if it was a patient that was already on cycled, doing that in combination and having them start it sooner in their cycled. I think for inpatient, sometimes it's a little bit more challenging. I know at our particular institution, we don't have any of the commercially available products on formulary. And so nebulizing 7 mLs is more cumbersome for the patient to have to do. So we don't typically resume that for inpatient, even for patients who are just on their chronic every other. So I think that may play into consideration, but definitely for outpatient, definitely a utilization since you can achieve higher concentrations, and that's theoretically the benefit of going the inhaled route. So I don't know if you have anything else you want to add to that.
We've definitely done that at our center. I guess I would say more so when I was working with the adult center, particularly for patients who had some sort of side effect or reason we wanted to avoid higher systemic exposure to aminoglycosides, like if they had any renal dysfunction. I think we've done it in pregnant women to avoid giving them higher systemic exposure. And then I guess my only other consideration with that would be how much like mucus plugging and blockages are we having to get past to deliver by the inhaled route? Because are we really going to get good lung distribution in someone who's already very ill and has a lot of obstruction? So I don't know the answer to that.
Well, we have 3 more for you too. Was the fictitious patient still taking inhaled anti-pseudomonal therapy? If so, the argument can be made that the absence of infection was due to the combination of both medications.
Both medications. What both medications? They were taking, I had them on cycled ACE-trianam, so they were still theoretically taking that, but just had not cultured Pseudomonas. But I think I'm missing both medications part.
Yeah, so that can be that just do the combination of both medications.
But I guess the question would be, are they not growing it because we're suppressing it with antibiotics?
Yes.
Yeah. So
that is definitely the
definitely possible.
Okay.
Thank you.
Okay, anybody else?
We didn't give our presenters a chance for rebuttals. So does anyone want to add any concluding last chance at the microphone? And if not, we'll let the battles end.
We will agree to disagree.
All right. Well, we want to thank everyone so much for coming.